Hi, this is Dr. Beals, and this is beginning week 4, and we're going to discuss several topics, including patient education, mobility, hygiene, and I'll be posting these videos for each chapter under the week 1 4 video presentation. So, without further ado, let's begin with the first chapter and our objectives. So as listed here, you'll note the objectives for patient education chapter. And I would like you to take note of the highlighted terminology in each chapter in the textbook. So we recognize how important that the Nurse Practice Act is when taking care of patients from all types of settings and patient populations. A patient teaching is no different. So we use the Nurse Practice Acts along with recognized standards for patient care, like the Joint Commission, the American Nurses Association, which sets the standards for our patient and families' education. Nursing is very much a collaboration with other health professionals. And in doing so, we enhance the patient's safety in achieving those outcomes that are positive for the patient and patient centered. It's important for us to stay up to date with our current practice and the standards of practice in different specialty areas, but particularly in the specialty area that you will be working. For example, a nurse that may have expertise in the area of obstetrics or labor and delivery may not always have the latest up to date treatments or recommendations, practice standards for conditions that are common, say, in the surgical area or the medical surgical area. So it's important that we keep up to date on these, and in doing so, it helps us to provide the most current education for our patients. So, in addition, we provide education not only with acute care problems in such settings as the hospital or different specialties, but we also have a responsibility in terms of preventative health education, in health maintenance, and disease management. So, as you learn about the physical and the psychological well being of your patient, we tailor that education, being knowledgeable on those particular areas. For example, preventative health care helps us to assimilate new knowledge into facilitating patient knowledge with healthy foods, the importance of gauging in physical exercise, and potential harms such as environmental or substances that can harm a patient and their family and the population. So, success in patient education is not the ability of a patient to simply recall that information, but to provide that information so they have the ability to incorporate these aspects into their everyday life to promote health. So, as you learn about patient education, you'll also learn about different mindsets of understanding how we learn as human beings. And that is an important insight for nurses, such as readiness or a patient's willingness to learn or their motivation to learn. That can vary greatly from patient to patient and population to population. For example, family caregivers, they're usually given as much education as the patient because, generally speaking, a patient may not be willing or motivated or interested in learning what you have to teach them. So, including the family in the teaching plan can be very beneficial. However, if you exclude them from the teaching plan, this often creates a barrier or conflict in being able to provide appropriate care for a patient when they're not fully recovered from an illness or injury. So, teaching is the concept of imparting knowledge through a series of directed activities. And learning can be conscious or unconscious. So, we want to promote permanent change in behavior. That's the aim of teaching and learning. So, we can achieve these lifelong benefits for the individual as they acquire the new knowledge and skills and the attitudes that will help them to be healthy. It's both a process of understanding, but also in applying these newly learned concepts. For example, your adult that is being taught medication safety, or perhaps we're teaching them how to successfully set up their weekly medications using a pill box correctly. We also want to be able to help that patient to transfer that learning as they demonstrate how to do this for themselves or even for their family. So, teaching and learning begins when a person identifies that they need to know something, and then they acquire that knowledge and are applying that knowledge. Teaching is most effective when it responds to a learner's needs. So, an important aspect of teaching patients is, as the educator, we need to assess those needs by asking pointed questions and determine what their interests are. And as you've learned in previous weeks, communication is so very important to the teaching and learning aspect in terms of overall patient care. So, what is your role as a nurse in terms of teaching and learning? Well, you have a very important role. In the American Nurses Association, actually has a specific statement that um, delineates the importance of that role for our patients. So we are legally responsible for providing education to our patients, but it's very important that that knowledge that we impart is accurate and that we're considering the patient and their rights in receiving that information. The Joint Commission is one of those many organizations that, as you have learned, is very important in terms of standards of care. Their Speak Up program helps patients understand their rights when receiving medical care. And Speak Up can be delineated down to an acronym, or Speak Up, and each letter will is defined by certain ideas. So, for example, speak up if you have a question or concern. P, pay attention to the care you get. So, those are helpful things that we can teach our patient in our evidence based and promoted by safe practice. We have to carefully determine what patients need to know, but we often have to consider their particular circumstance, their preferences, what their existing knowledge is, and even what their existing ability to attain knowledge to be able to educate them effectively. So, the steps of the teaching process are very similar to those of the communication process. We have to first identify a need for information. And sometimes it's not quite so obvious, like in discharge planning. These ideas can come up, or factors can come up when taking care of patients. So perhaps they need more education on, you know, their being able to determine what foods are healthy for themselves. We have to establish learning objectives. Now, this can be formally done or informally done. So, as you've come to find out, learning objectives are very important because they serve as kind of a roadmap. So, what are we trying to accomplish? What idea are we trying to convey? The nurse is the sender of that information, and the patient the receiver. So, sending and receiving a message. And then we need to provide them feedback. So, um, this helps into facilitating their understanding of that information and what that means to them in terms of their care. And then we go back full circle and evaluate the success of that teaching plan. And as you go about the program, you will notice that this is a cycle. So just like the nursing process and thinking about clinical judgment, it is cyclic. So we always are going full circle, coming back around and reflecting upon, well, did this work? Did that not work? Maybe the patient's not receptive to the message. Maybe they're not ready to learn this yet. And then we can reformulate our plan of care. So, domains of learning. There's a great box in your textbook, box 25.2, that gives you examples of the different types of learning. And most schools of thought narrow this down to three, and that's cognitive, affective, and psychomotor. So, cognitive learning, that's the knowledge aspect. So, what would be some example methods of imparting knowledge from the cognitive domain? Well, perhaps like what I'm doing right now. So, we present to our patient. And then the affective learning. Affective is mainly dealing with behaviors. So, for example, my ability to be empathetic to patients. So I'm looking at that subjective side to learning. And then psychomotor is dealing with skills, just like you're learning in lab, all the different skills by demonstration and return demonstration, and looking at your clinical modules and working through those. So you're looking at a skill. So, what would be an example of this for a patient? Well, perhaps helping that patient to learn how to give themselves insulin if they're a diabetic. So, drawing up the medication in a syringe and then going through all those safety factors, cleaning the skin. What do they do with the used needle? Those are skills that falls within the psychomotor learning domain. So take a look at that box, and I think that will be very helpful in providing additional example methods that are in each of these domains. All right, let's do a quick check. So think about this for a minute, and we just discussed this. And here's the answer. So, yes, this is the psychomotor learning, which acquires a motor skill. So, we're looking at their ability to coordinate their physical movements in this particular skill. So, they're learning how to use a glucometer or a blood sugar testing device where you stick your finger and the device measures the amount of blood sugar in the blood. So that is a skill and it falls under the psychomotor learning domain. So patients need knowledge for survival. And if they have this, they have a stronger motivation to learn than patients who need it for promoting health. So this is very interesting concept, but is very common to human nature. We can use a type of interviewing technique called motivational interviewing, which has been very successful in those patients who do not appear to be motivated by change. So, for example, you're providing education on smoking cessation to a long-term smoker. So that patient may not be motivated to change. And the objective of motivational interviewing is to not solve the patient's problem or even develop a plan. We want to help that patient resolve their ambivalence about adopting a new healthcare behavior. So, helping to resolve that conflict within themselves in terms of making those changes that are necessary for their health. In doing this type of interviewing, oftentimes it gives us some motivation or some momentum, um, and helps the patient to believe that behavior change is possible. So, some basic learning principles include the motivation to learn and readiness to learn. In these types of principles falls under a particular theory called the social learning theory, and it's one of the most useful ways to approach patient education and even education in general. And what this theory says is that it takes those personal characteristics of the learner, their typical behavior patterns, the environment that they're in, and it helps guide the educator in developing effective teaching strategies that will hopefully motivate and enhance their learning. So, a part of this social learning theory is that the patient's state of mind or the person's state of mind in those intrinsic or internal motivational factors are very important to reinforcing the behaviors or the behavior change that we're trying to go about. So, for example, an internal motivation factor would be that sense of accomplishment or increased self confidence. This type of internal reward system allows a person to attain desired outcomes and avoid undesired outcomes, which results in improved motivation. And it also reinforces the concept of self efficacy. So, feeling satisfied within yourself with the accomplishments that you have made. Motivational interviewing techniques incorporate this self efficacy principle. So, we use this theory to enhance motivation and learning, and we also want to consider cultural factors. That can be very much a factor in terms of motivation to learn. So, here's another great acronym, and that's the ACCESS acronym model. So, it looks at the assessment of a patient's lifestyle, their cultural traditions, their health practices, communication within an awareness of verbal and nonverbal responses. We might consider cultural negotiation and compromise, and that helps to encourage awareness of the characteristics of a patient's culture and our own personal bias, because we all have them and we have to be very aware of those. Establishment of a respect for that patient's cultural beliefs and being sensitive to the fact that we all come from diverse backgrounds and how we approach that is important in education. And then safety, making that patient feel safe um, and accepted will help empower them and avoid disempowerment in terms of their cultural identity. Now, a patient's readiness to learn is based upon their willingness to engage in the learning. So, we have to be engaged in that knowledge, information, in changing our behavior. A loss of health is usually very difficult for patients to accept, and they will go through the grieving process. In that grieving process, there are several different steps, and you'll learn about one of the most recognized processes of grieving. That's a framework by a theorist, Kubler Ross. And it's that we all go through these different stages um, of grieving. A couple of examples of these stages include bargaining, and then the final stage is acceptance. So, that relationship between the psychosocial and illness and grief and learning can greatly affect their readiness to learn. Grief is a process and it's very complex. And even though we all go through these stages, we don't all go through them the same. So, for example, a person may get stuck in the bargaining stage. So, for example, they'll always try to negotiate. I'll change my behavior if I'm allowed to live. So, that patient's not willing to accept their own limitations. And hopefully, in understanding this, we can help our patients to process through these stages to facilitate an adjustment, whatever that might look like for their illness and disability. Now, we have talked quite a bit about the different developmental aspects of care, and it also applies to a person's ability to learn, and we have to consider that as an educator. So, the ability to, or the capability to learn is affected by an human being's individual developmental capacity. For example, we don't approach learning and teaching of school age children the same as we do an adolescent. So, if I were going to be teaching a school age child about healthy eating, I would approach that very differently from an adolescent. An adolescent wants to make decisions about their own health and health promotion, and they're very much in the problem solving and learning how to problem solve developmental stage. So I want to approach that teaching collaboratively with them, helping them to maintain their autonomy or their developing autonomy, as opposed to a school age child, which is very, um, I might want to consider, very literal things, such as in this picture here of showing colorful vegetables and fruits and what that means to them in terms of healthy eating. Adult learners have their own aspects of learning as well. And some things to consider about adult learning is the level of health literacy. So, health literacy is those cognitive and social skills that help the ability of the individual to gain access to understand, and to use information that promotes good health. And health literacy pertains not only to a patient's ability to read and comprehend health related information, but how they transcribe those skills to problem solve, to articulate, and make good health care decisions are another aspect of health literacy. People at risk for low health literacy include older adults, minority populations, immigrant populations, people of lower socioeconomic status, people without a high school education, and even people with chronic mental and physical health conditions. Now, your textbook gives an alarming statistic in terms of health literacy, and that is that 9 of 10 adults struggle to understand and use health information if it is unfamiliar, complex, or uses jargon. So, jargon is those words that we often use in healthcare or in language in general that really doesn't have a defined meaning. So, it may mean something to us in this culture, but it could mean nothing to somebody else in another culture or part of the country. So we want to avoid using jargon. So making sure that what we're speaking and how we're speaking is clear, and helping that patient understand any unfamiliar terms. Our learning environment's important as well. So we want to consider a patient's environment that we're in, so we can teach them according to that environment. For example, they may not be able to see very well, they have poor eyesight, they can't grasp tightly, which is common among older adults. They may have difficulties with coordination. So, thinking about those physical capabilities that will impact the learning environment. I think your textbook does a great job at centering our mindset in terms of nursing care as looking through things through the patient's eyes. So, the patient is at the very center of everything that we do and everything we think about. And teaching is patient centered. So we have to think about questions of that's patient centered. So what do you want to know about? What do you want to know about your illness and your treatment plan? Which experience have you had in the past that are similar to those you are experiencing now? So we work together with the patient to try to determine what is the most effective way of educating them, and to be able to determine what information they need to know or they're wanting to know. Think about it this way: when you give directions to your house, do you tell people how to get there and write down the instructions or draw a map? So we have to consider the receiver of that message in order to determine a good plan. Okay, let's go. I'm going to introduce you to La Quinta, which is a 55-year-old Bosnian immigrant. She's overweight and is concerned about her health. She has come for her yearly physical, and the nurse taking care of her is Ashley, and she's assigned to her care. During their first visit, Latinka states, "I am interested in getting some information to help me become healthier and lose some weight." So, questions that we need to think about are this: is this an adult learner? If yes, do you approach this differently than an adolescent or school age child? Absolutely. We want to consider her culture. We already have identified that she's a Bosnian immigrant. We want to consider health literacy. Remember the statistic that I gave you: 9 in 10 adults. Does this patient have any learning disabilities? Is she motivated to learn? What indicates in this first slide on the case study that she is willing and motivated to learn? So, how do you approach it in the terms of domains of learning? Could this be cognitive, affective, psychomotor, or perhaps we use aspects of all three? And would her medical history be relevant? Absolutely. So, we've talked intermittently about nursing diagnoses as being problem statements. So, some common nursing diagnosis problem statements for patient education are as follows: impaired health maintenance, impaired ability to manage dietary or exercise regimen, self care deficit, lack of knowledge, whether it be affective, cognitive, or psychomotor, and decisional conflict. So, these are great problem statements or nursing diagnosis that helps to guide our plan of care. When you're developing a teaching plan with your patient, timing is everything. So, when is the right time to teach? Before the patient enters the hospital, or when the patient enters the hospital? At discharge or at home? So, we have to consider each patient individually and tailor their learning needs, always considering the timing of the provision of that education. We wouldn't want to teach a patient about their care with surgery after they have during the time frame that they have had the surgery or immediately after, because they may not be aware enough or willing or ready to physically and psychologically receive that message on the teaching. So timing is everything. During this planning process, we want to remember collaborate with our patient. So asking or encouraging the patient to offer suggestions. When would be a good time to talk to you about this? Or tell me when you're ready to talk about this, and I'd be happy to provide you with that information. Setting goals and outcomes are an important part of teaching as well as patient care, and we want to set those up to try to help the patient be successful in reaching their goals and having those positive outcomes. So we set priorities, thinking about the timing, organizing the teaching material, and then if need be, we collaborate with other healthcare professionals that may have a specialty area. For example, diabetes educators. Often are an excellent source of patient education when it comes to that particular disease process. So, always remembering we have these other members of the team that can help us with the planning. Now we're ready to implement. So, we're maintaining learning, we're having the patient, we have their attention and they're participating. We're helping build upon what knowledge they have. So we have to know that in advance in the planning stages. And then we are teaching approach. So are we telling them? Is it participatory? So they're actively engaged. We're reinforcing what they know and what we're teaching them. So we constantly incorporate teaching and nursing care. Even I think sometimes for you all it will be very deliberate, but as you gain experience over time, you'll find yourself teaching a patient even without thinking about it. So it becomes quite intuitive as you gain expertise. Now, teaching can also be very formal. So for example, using the educate model with verbal one on one discussion, or maybe a group instruction, or demonstrating analogy. So, telling a story like I often do in class. Role playing and simulation can also be aspects of teaching strategies that we can use. When we're implementing our teaching plan, we want to consider additionally illiteracy and other disabilities, such as cognitive disabilities. We've already talked about cultural diversity and what that factor can play. And some teaching tools that we can use, one common one is called the teach back method. And it's very much a form of closed loop communication. So I teach a patient the information or the skill or whatever it might be, and then they teach it back to me, and it closes that loop. Your book gives a great example of the use of the teach back method when you're trying to teach a patient a skill such as self monitoring their blood glucose, just like in our quick check question. So we can use this method to determine where the gaps in learning are, or maybe they need to practice more with manipulating the supplies and the equipment. So and it helps them to take ownership of that, what they're learning and the experience um, for the patient. So we're looking through the patient's eyes, and now we've come full circle and we're thinking about evaluating our teaching plan. Um, so we're reflecting upon, has the patient's learning needs been met? If not, then we go back and revisit that plan of care and offer additional instruction or reinforcement depending upon their needs. We look at those outcomes. Maybe the outcome that I originally set for my patient is not realistic. For example, it would not be a realistic outcome to expect a patient that may have some cognitive impairment to be able to self monitor their blood sugar. But we can involve the family. So I would go back and recreate my goal. Now, when you're creating these goals, you want to make sure that you're using SMART goals. So they're specific, measurable, achievable, relevant, and time bound. The information on this slide gives some great questions that you can think about as you're developing your own skills with creating SMART goals for yourself and for your patient. And then document, document, document. So we're always documenting what we're teaching, how we're teaching, um, the patient's response to that teaching. So we can review that, and other healthcare providers can review that and adjust that plan of care as needed. All right, let's go back to our case study. So before she meets with Latinka, Ashley decides to read about the Bosnian culture. That sounds very reasonable thing to do. So, we cannot know everything about everything. So the important part to that is we have to be willing ourselves to learn and to recognize our own bias. So recognizing we have a learning gap in terms of understanding this culture. So, among other things, she learns that Bosnians tend to have strong ties with their families and their community. And when they speak again, Ashley asks more questions about that community and learns she's very close to her children and neighbors. So, how can we use this information to help tailor our plan for Latinka based upon the information? Interestingly enough, many people often do well with exercise plans when they can have a accountability partner and exercise with other people or in a community. So that might be a good thing to incorporate in this patient's plan. All right, here's another quick check for you. Okay, here's a test taking tip. So when you encounter the select all that apply, take each answer choice and answer it as a true or false statement. Okay, so here's our answer. So if I look at each one of these individually, state goals of the session for the patient, that would be false. Remember, we work collaboratively for the patient. So why is A incorrect? Well, stating the goals for the patient takes away the intent of the educational experience, which is informal. Um, and it's aimed at the patient identifying their own goals, which can help their self confidence and levels of self efficacy. The nurse has goals for teaching, true. We have to have goals for ourselves or objectives to help prepare for that educational session. But those goals are specifically for the educator, not for the patient. So, for example, a goal for the nurse educating the patient would be to use the teach back method. So we do want to repeat the most important information. We want to practice empathetic skills, and active listening is another thing we want to practice. Be aware of our nonverbal messages and use a standard question list for chosen topic. We wouldn't want to do that because remember, the patient is the center of everything. So we want to tailor that and individualize it according to the patient's situation. Okay, well, that concludes the first chapter. So we'll continue on with chapter 38 with the next video. Thank you very much.